Good morning, everyone. Hope everyone had a nice evening. It's great to be back this morning to kick off the day with some cases. So you'll find maybe some connections with some of the themes I touched on yesterday, but would love for this to be interactive. So please, chime in and at any point questions. Chime in with questions. So we'll just jump right into the cases. So usually we'll give a little bit of a history, sometimes no. Sometimes, as you know, we don't have one, but in this case we did have some good history. So we have a couple of T2 FLAIR images on the left-hand side, and then DWI and ADC. And maybe, is it projecting well, or are you getting still some too much light on the screen? It's okay? Okay, you have good contrast, is it? It's hard to tell. Okay, yeah, I think maybe that's a little better to get a sense of what we're seeing on the ADC. So what are we seeing if you're describing the process before just jumping to a diagnosis? What are we seeing? Yes. Yes, so this is bilateral, symmetric, posterior predominant vasogenic edema, and purely vasogenic based on the diffusion image that I'm showing you, because this is just a normal DWI of the cerebellum, and you can see that there is elevated diffusivity on the ADC map. And this is consistent with, and here the history is very important here as well, because you're given a couple of, an acute clinical presentation, which is common in PRES. Seizures can be seen up to 50% of patients with PRES, and hypertension, which is the classic presentation. It used to be called hypertensive encephalopathy, but we'll talk about it in a moment why that's no longer used. So this is a presentation, and in this case, it's fairly simple as far as management. It's blood pressure control and anti-epileptic drugs, and complete 100% reversibility, consistent with this classic uncomplicated PRES. And looking at PRES, it's I alluded to some of the pathophysiology yesterday in the stroke versus mimic talk, but it is this hypertension. There's probably at least two mechanisms involved, because the classic, and this makes sense, systemic hypertension, high blood pressure, you have plus failed autoregulation. You don't have an appropriate vasoconstriction of the cerebral arterioles, and then therefore you get more perfusion and interstitial edema and vasogenic edema. 100% of patients with PRES have brain parenchymal vasogenic edema. If you don't have brain parenchymal vasogenic edema, you don't have PRES. But additional findings may occur, and actually up to a third of patients are not hypertensive. So if you see something that looks like PRES and the patient is normotensive or even hypotensive, that does not exclude PRES. It does not exclude PRES. You should look for the other risk factors that they may have, because often these are sometimes very sick patients who are septic and maybe hypotensive and then getting pressors in the ICU. And that probably plays a role in the pathophysiology, but endothelial dysfunction also plays a role. So you have this leaky blood vessels, and sometimes you can see enhancement, sometimes it can be really loss of the blood-brain barrier, and you develop this brain parenchymal vasogenic edema. Does anyone remember from yesterday how commonly you can get restricted diffusion? A component of the abnormality has cytotoxic edema in PRES. Does anyone remember? What's that? About how much? With what frequency? I mean, there's a range in the literature, but. I don't remember. Yes. Yes. Excellent. Yeah, well, that's on the lower end of the range, but 10 to 30% can have restricted diffusion. And that probably depends on your patient population, how sick they are. It tends to be a more severe PRES phenotype, and it is associated with worse outcome in the literature. So when you see cytotoxic edema, it makes sense that there's less reversibility there. But it's about 10 to 30%. Some of the bigger studies has about 1 in 6 patients will have some cytotoxic edema. And often you're going to have other things in the differential. And excellent hemorrhage. Hemorrhage commonly occurs. And the rate of hemorrhage just almost completely depends on the sensitivity of your imaging modalities. So older studies with just CT or the very rudimentary, gradient echo had lower rates, and SWI has a 50%. And so, it's hemorrhage, microhemorrhage is very common. Hemorrhage with mass effect is about 7% of patients. That also, when there's a rank hematoma, that also is associated with worse outcome. But in general, even in those cases, these tend to be reversible if the underlying insult is addressed. Any questions on PRES before we go into? Yeah. Yes. Yes, and often, so that is more classic, like as in this case, that's more classic to have cortical and subcortical with relative sparing of deep white matter. I have a couple of cases where it's only deep white matter, only callosum even. I mean, it can be there is atypical PRES. So it's a great question. I wouldn't eliminate PRES if you have brain parenchymal vasogenic edema, even if it's just deep white matter, but it's just much less common. And then other things are probably going to be higher in your differential. Those cases were only diagnosed as PRES in retrospect when it resolved with, or there was a very high clinical suspicion. So it's a great question. There's often a differential. Yes? Oh, yes. Great question. You can, sometimes these are very ill patients who cannot go for MRI or, for various factors, practice setting, you have less access to MRI. You can see PRES only on CT, but it's not sufficient to say no evidence of PRES. If I have a head CT where it's just a very leading history, let's say there are 4 PRES risk factors in the history, and the head CT looks normal, I do not say, I don't say no PRES. You can say if it's a normal brain MR, if it looks like these T2 flare images all the way out, you can say no PRES. Not no evidence of PRES, no PRES, because there's no vasogenic edema. But with a CT, it's not as sensitive. Now, if the patient just can't go for MR, then you can say, yeah, there's no evidence, but it's limited, and in this clinical setting, which is a high pretest probability for PRES, you should get an MRI if possible. So yeah, it's a great question as well. Other questions before we get to the next case, which gets into a bit of a differential. 59-year-old with weakness and altered mental status, less leading history here, and so a lot of images, but we have diffusion images on top with 1 ADC or 2 ADC images. T2 flare, and a susceptibility, T2 star gradient echo image on the bottom right. So a lot of images to kind of orient yourself to, but what process are we seeing from the most basic findings perspective before we jump into a differential?
There is no evidence of hemorrhage or calcification in gradient echo, and there is no
Excellent. So, and that's excellent. No diffusion restriction, no cytotoxic edema here. So this is a process, another vasogenic edema, bilateral, a little less symmetric, and you used a great buzzword there because I mean the very good recognition that it is involving the juxtacortical white matter. So those U fibers just hugging the cortex, just right up against the cortex, are involved here. Yes, they were involved in the previous case, but in a slightly different fashion. I mean, here you have it going right up to what looks like otherwise close to normal cortex on this side and right here. There is some gray matter involvement here, but much less than white matter. So that's a really nice recognition. So we have a bit of a differential. So anyone thoughts about what differential would be? ADEM, yeah, excellent, excellent. So acute disseminated encephalomyelitis. So we're going to be looking in the history for potential risk factors for that, as well as potential risk factors for PRES. I mean, PRES is on the differential here, and it was prospectively on the differential. But we had some conversations with the neurologists. You know, you could expand the differential a little bit more, but those really are the top two. And so we had discussions. Are there PRES risk factors? No. There were no identifiable PRES risk factors among the laundry list. There are many, as I went into yesterday. But there was a recent viral illness, and they even established a diagnosis of metapneumovirus, which is really elevates the suspicion. So what they did was they treated this patient as a working diagnosis of ADEM. They treated with IVIG, steroids, plasma exchange. And the patient did improve substantially here, but they did have a persistent paraparesis here. So this was a more, and you see in the follow-up, there are some areas of, some almost really encephalomalacia, some gliosis here, and there was no hemorrhage, which is a pertinent negative on the initial study, but some hemorrhage did develop here in the left parietal lobe. And this is one of my colleagues, a neurologist, kind of summary of the case, a few months later. Suspect ADEM, given the preceding viral infection, predominantly white matter lesions, improvement with immunosuppression therapy, inflammatory CSF, I didn't mention the lumbar puncture showed inflammatory CSF, and then lack of restricted diffusion of brain MR. Less likely, and even in retrospect, he's including a little bit more of a differential. And the patient did have a viral illness, so it could, metapneumovirus, I've never seen it look like this, but that's still plausible. It could have been potentially a viral encephalitis, but this is most likely ADEM given the imaging findings. Okay, next case. Here, no history, just 3 images. Diffusion, ADC, and T1 post.
There is a
Yes, this is tumefactive demyelination, and you picked up on this enhancement pattern of the incomplete ring enhancement. And this is another one, I could have had, it's a little bit less of a stroke mimic than yesterday. You see a theme here, I have a lot of pathologies that restrict diffusion that are not ischemia. But this is one where, there's a lot going on here pathophysiologically. There is a lymphocytic infiltrate that might be part of the diffusion signal. There's probably some component of some cytotoxic edema, very small component, maybe intramyelinic edema. It's multiple factors combining, and then this loss of the blood-brain barrier with discontiguous rim enhancement. And this was a young woman. This is something we do not want to biopsy this. If you see this on your brain lab in the morning, before the morning of surgery, you call your neurosurgery colleague immediately and you say, we should wait here. an extra few weeks is not going to make the difference in the unbelievably unlikely scenario that this is a glioma. And it's going to be risky. You can see here, as you mentioned, this is now involving the medial aspect of the prefrontal precentral gyrus. So this is the primary motor cortex and the region of the leg and the trunk homunculus. So it's a morbid biopsy, even if you're taking a tiny amount of tissue. So excellent job recognizing that tumefactive demyelination. And it almost has that Bailos concentric sclerosis concentric rings as well, which is related to this. But I don't have a good T2 image to show you that. Questions here? Much lower would have been a primary glial neoplasm. Astrocytoma, oligodendroglioma, much less likely. I mean, the clinical factors are going to play a role in that. Did they, have they had prior? I mean, many of the times this is a single monophasic event. But if they have had previous demyelination or have a family history, that is going to play into it. But I think much less likely would be an intraaxial tumor. I think anything else would be a little bit of a stretch. If you have thoughts on another differential, I'd be. I think it's spectroscopy can be good. I prefer it when it's in the deep brain parenchyma, because here this is a little bit superficial. If you get this might be big enough for a single voxel here to get enough signal to noise ratio. But if your voxel includes any bit of bone, you don't want to include bone. Even you don't really want to include vessels in the subarachnoid space either. But if the corner of your voxel includes the bone, I've found that it really degrades the image. But yes, that would be, and it would be interesting to see what this would show. On it. But I find spectroscopy in general to be a little bit more helpful in retrospect when you can fit the spectrum to what you know the diagnosis to be, rather than actually prospectively guiding your diagnosis. Okay, next case. Another diffusion restricting pathology. Absolutely, classic pyogenic brain abscess. Excellent. This sometimes, the only real mimic here is when you have, and I actually am not showing a T1, but this is so classic. This is enough to just have very top of your differential and think of anything else. Subacute hematoma can restrict diffusion, can have surrounding brain parenchymal edema, but is T1 hyperintense. So it's going to have some methemoglobin that is intrinsically T1 hyperintense, and that's the only kind of differential to consider on this. Which I didn't show you, but this is a nice classic abscess. Regardless of history, you're going to be leading with that. Great. Okay, 46-year-old, recent ruptured appendicitis, involuntary twitching. Oh, yeah, so these are fat suppressed T2 flare images, and this is the only diffusion image I gave you. So if you're kind of assessing the abnormality in the putamina, you can use this on it. So
Okay, so can it be a hypoxic ischemic?
that would typically, I think you have to have hypoxic ischemic, consider it when deep gray are involved, but no diffusion restriction. So these are the fat suppressed. We do a fat suppressed 3D T2 flare, so it sometimes can look like a diffusion weighted image here. But yeah, this is the single DWI image, and this is the ADC. And so, I think considering it and then saying, okay, well, even if it were in the subacute stage, you should have some diffusion signal there with it. And this is a really atypical case. And to your earlier question, and this diagnosis was not made prospectively. I'll be fair, and I don't think I would have made it even prospectively. But this, you have to think of toxic metabolic, and I showed a couple of cases of a toxic metabolic insult, and then you're going to be scouring the chart. The neurologist is going to be scouring the chart. Is there anything that could cause this? And does anyone know of a particular toxic insult that can involve the putamen?
Yeah, methanol poisoning.
Yes, methanol, and that was included on the differential. And it's easy for me to say in retrospect, but why is that? It can look exactly the same on T2 flare, but what do you typically see on diffusion? Is it something that's just vasogenic edema? This is purely vasogenic edema based on imaging, or is there cytotoxic edema, necrosis? Yes, absolutely. So that one would have been very atypical. I haven't seen a lot of methanol cases, but it would typically be necrotic. So that's what we favored prospectively, toxic metabolic etiology, including methanol. And I think that's a fair report, honestly. 3 weeks later, completely resolved. They had this ruptured appendicitis. They had some infection. They had some inciting factor, some endothelial dysfunction. And even looking back, I'm not sure if the diagnosis of PRES was made here at all, but it was almost definitely PRES, given how it's fully resolved. And looking here, this is what a methanol toxicity looks like. Now, this is in the subacute stage, so this was a few weeks after. But you have extensive cytotoxic edema, really a hemorrhagic necrosis of the putamina and the caudate heads in this case, but sometimes it can be just putamina. Okay. Okay, next case. So here I'm just showing you, it's actually very hard to tell the difference between these three, but these are DWI. And this is a fat-suppressed 3D T2 flare that we reformat. And this is ADC. Non-alcoholic fatty liver disease presenting with altered mental status. History of lupus. On some, I forget the exact therapy that they were on, but they were on some immunosuppressive therapy. Absolutely, yeah. Any differential or any suggestions of what to? What is the insult there? Medial temporal involvement. Yeah. Yes. So that's the kind of the leading differential: herpes encephalitis or post-seizure effect, where the are kind of 2 on the top. You kind of look for, I mean, they have risk factors for both. So this patient needs, this patient did not have seizures, no history of status epilepticus. And so here we led with herpes encephalitis, and they did a lumbar puncture and confirmed this was HHV. And yeah, well, it's hard. This here, I'm not sure if that's technical, because the real process, as you start highlighted, was in the medial temporal lobes, the hippocampi, the amygdala, medial temporal lobe. So this was confirmed HHV6 encephalitis. Yeah. Yeah, and if it is, I mean, the other cortex that you can have involved, as in the case yesterday, is the insular cortex, the insula. And interestingly, I'll just give a little follow-up here. You know, they were treated with IV ganciclovir immediately, which was appropriate treatment, but you can see there was some volume loss here related to it. But their biggest insult was their biggest clinical limitation was hyperhidrosis hypothermia syndrome due to hypothalamic involvement. And looking back, you can actually see this. The hypothalamus was involved actually here. And interestingly, you know, sometimes these patients can develop profound memory loss. For those of you who have seen patients who've had herpes encephalitis, they can have significant long-term memory loss. This patient did not fortunately have so much, but a very small hypothalamic involvement can be the most clinically significant long-term. Okay, I think we can run through a couple of quick ones here. Thank you for your participation and questions. But this patient has had a recent diagnosis of C. difficile, and you can see another case of brain parenchymal vasogenic edema, but in a very specific pattern. Structures are involved here.
This one includes sclerosis and region of the fourth ventricle, and it does have.
Yeah, and the dentate nuclei as well, right? Dentate nuclei. And then anything that they might have been. NMO. I think that you have to consider that, but this is more, and that would be more likely to involve the dorsal brainstem, periaqueductal gray. I think that's a good differential to consider here, but this is mostly confined, I'm not showing you all the images, but to the dentate nuclei, and then here splenium of corpus callosum, a little bit of white matter as well, and it's vasogenic edema, and anything that could be related to C. difficile infection. How would they be treated? What's that? I'm sorry, I didn't hear. Oh, it is the treatment for it, but it's of which drug though? It's actually Flagyl or metronidazole. Yeah, Flagyl. So this is one of those that is a little more of a typical. It's rare, fortunately, but it's one, and that radiographics paper goes through them when you see this bilateral symmetric signal abnormality.